teachers of clinical examination, so they've been around for a long time. So listen to what they say.
So we're going to move on to the spine. It's important to remember that the examination is just part of your assessment. There's the history and investigations as well. And a lot of what we've been talking about today is pattern recognition. So if they've obviously got a flat foot, for example, you're going to concentrate on that, and it's exactly the same in spines. And there are some classic cases. If you see a patient who's got an obvious scoliosis the moment you look at them, examine the patient for their scoliosis. Don't get waylaid. One of the problems in the exam is there's something clearly and obviously wrong, and you go off on a tangent doing your whole encompassing examination, and the examiner gets irritated. So there are some classic cases that come along, and you need to know about some of these. The history will tell you most things, and the examination is either just to confirm that, confirm your clinical impression, or suddenly it makes you think again, ooh, could this be something else? You need to focus in and widen out when you're examining a patient. Today is all about how to structure an examination, eliciting physical signs, some interpretation of those physical signs, and whatever you want clearing up. And we've talked a little bit about the exam, but the short cases is all eliciting physical signs. Sometimes you'll be asked, can you examine this patient's hip? But you might be told, this patient has an unstable ankle, show me 2 tests, for example. So always listen. And so the short cases are all about eliciting physical signs. And in the exam, there are good candidates who can do a focused and clearly good physical examination in just a short time, and the learner can do the same thing in under an hour. Some things not to miss. Not all groin and thigh pain is an L2 radiculopathy. It could be a hip, it could be a whole stack of things. So always think of some other things. Diabetes, think of neurological disease. Don't jump to conclusions. Shoulder pain. In the exam, you occasionally get patients with neuralgic amyotrophy, Parsonage-Turner syndrome, so think of those. This is a very good resource, and a lot of the rest of my lecture is taken from Fazal Ali's lecture, which incorporates pictures from his book. That's a pretty good book. So Graham Apley, look, feel, move, special tests. You've heard that from every lecturer today, and that's the way to do it. Even if you know nothing, if there's some structure to what you're doing, the examiner may still be fooled, as may the patient. For starters, always think about whether you need a chaperone. Exposure, you have to expose the patient fully to see some physical signs, and you have to think, am I going to do this examination with them standing or lying or sitting or what, or in what order? The examiner gets irritated if you walk the patient, then lie them on the bed, then stand them, then lie them on the bed, then they're up again, and so you have to tailor it. You need to expose the patient, otherwise you'll miss things. You need to be able to expose the top of the neck, Klippel-Feil syndrome, or an Arnold-Chiari decompression or something like that, and at the base of the spine, sacral stigmata. And you don't in the exam, you just need to not really just make a show of it, but just pull the top of the pants down, or on the hip, pull the side of the shorts up so that the examiner thinks, good candidate, they're looking for the things that might be missed. And incredibly, you might have missed something, so it pays off. So you have to have a routine of how you're going to examine the patients. And my preference is for the lumbar spine. You see them walking, and as a couple of the other examiners have said, in the clinic, you see them walking down the corridor to you. And in NHS clinics, they're all lino floors, and so you can hear their foot drop gait. Trouble is, in the private hospital, you can't hear the foot drop gait. And then you can observe them walking across the clinic room to you and so forth. But in the exam, I'm going to stand the patient and walk them, and if the examiner wants you to do that, they'll get you to do that. Examine the patient standing, then for the lumbar spine, lying supine, lying prone, and sometimes sitting them on the edge of the bed. Cervical spine, walking, standing, sitting, and for neurological examination, lying supine as well. So you just have to have an idea. So you're going to stand and look, and what are you looking for? You're looking for things like deformity, steps in the spine, scars, stigmata, discoloration. From the back, you're going to look at coronal balance, asymmetry. Are there creases? Are the shoulders level? And if there is any asymmetry, you might start to ask the examiner for a plumb line or something, and he'll say, no, don't be so silly, and just move on. Look from behind, look from the front, look from the side. And it's quite useful to get the patient to turn, because sometimes they might be okay standing up, but the moment they start to turn, they may hobble or something. So get the patient to turn gives you useful information. Look from the front and in the axilla. In the axilla, you may see freckles or something. The examiner's quite like you looking in the axilla. Look from the side. Look for sagittal balance and sagittal plane deformity. And these are from Favel's slideshow. And you can see all of these patients have some deformities. You just need to be sure what you're looking at. And be able to describe them properly. And remember that apparent hyperlordosis of the lumbar spine can be secondary to hip fixed flexion deformity. Look from behind, and you're going to be looking for curvatures in the spine. Know what you're talking about. Scoliosis, you need to be able to define what a scoliosis is. You need to be able to talk about kyphosis, loss of the normal lumbar lordosis, and just describe what you're looking at. And that's often the starting point. If you can describe what you're seeing, then that's half the way to getting the correct diagnosis. And if you jump in straight with this is a scoliosis, the examiner may take you back a step. Hold on, just describe what you're looking at. And that's very important. And sit the patient down at some stage. Adams forwards bending test. This is shown here. Bunnell angle using a scoliometer. So if you stand behind a patient and say, I can see there's malalignment in their coronal plane. I think this patient has a scoliosis. I'd like to just check their forwards bending test. The examiner will be quite happy with that because you've moved on to do the next stage of a scoliosis examination. Sorry. Always be aware that if there's a leg length discrepancy and a pelvic tilt, there'll be an apparent deformity of the spine, and you can just check on that by sitting them down on the edge of the couch. So that's looking, because in the lumbar spine you can't really palpate next with them standing up. You do the palpation when they're lying on the couch. I go on to moving the spine, and you're looking for stiffness, you're looking for deformity that's disclosed or abolished with them moving, and you need to know whether they're in pain. This is forward flexion of the lumbar spine. You should always be aware that patients can have very stiff lumbar spines but very mobile hips, so always have a think about where the movement's occurring. I always look at them from the side initially, and some patients with ankylosing spondylitis can touch their toes, but there's nothing in the lumbar spine, it's all in the hips, so just be aware of that. But if you do want to measure it, have a think about how you're going to record it. In real life, almost no one does Schober's test in the clinic. They record it fingertips to mid-shins or something. But if you want to do Schober's test, we'll go over that. Think about that, and think about what's meant by an extension catch. We might talk about that this afternoon. Extension of the lumbar spine. How's this recorded? And what does pain on extension mean? Lateral flexion. How are you going to record this in the notes? And rotation. Well, where's that occurring? Is that in the lumbar spine? You need to know where some of these movements occur. Neurological examination, while you can do a little bit of it while they're standing up, so just get them to tip back on their heels or stand on tiptoes, particularly if you think there is a neurological problem coming up. Then, having done that, you need to lie the patient down. It's always quite sensible to always just put a hand on the tummy if they're lying on their back. It's always very embarrassing to miss an aortic aneurysm, which you only pick up on the lumbar spine x-ray. So always think of that. Palpate the spine, palpate the pelvis. You need to go on to a neurological examination, and you do other special tests while they're lying on the bed. You'll be examining the patient both on their back and on their front. What I do is I say, can I ask you to lie upon the couch, on your back, head on the pillow, face the ceiling? And if they do, despite all that, lie on their front, I don't make an issue of it. I just examine them with them on their front to start with, and then ask them to turn over. Rather than saying, you silly old moob, can you turn over? Spinal palpation, so you have a look, you need to examine any masses or lumps, that's rare. Steps and gaps, you see occasionally, and you might be having a think about why they're nearly always at L4-5. And tenderness, and spinal tenderness, does it mean anything at all? We talk about facet joint tenderness, but it's under 4 centimeters of muscle. Does it mean anything at all? And then a neurological examination. This is very important. It's surprising how often you'll pick up a neurological abnormality, and it will refocus your thoughts about what's going on with the patient. And again, you need to have a system. So think about tone, power, reflexes, sensation, some order in which you do all of these things. If you have a practiced order in which you do them all and you've got a pattern in your head, you won't miss something out. It's very embarrassing if at the end of the neurological examination someone says, so should we do the reflexes now? So you always need to have a pattern in your mind. These are some of the dermatomes. You need to have an idea of the dermatomes of both the upper and lower limbs and the trunk, of course. You must know some of the autonomous zones. It's no good just wafting your hand vaguely around the leg and saying that seems normal, because the examiner will say, so where's the autonomous zone for L5 then? And you say first web space, tick. And that's very important because there's quite a lot of crossover. Don't forget Cordra-Quina syndrome. In the exam, you'll never do a PR, but it's always worth saying, and I might consider a PR examination if I were in the clinic. You need to have a fairly good idea of what the myotomes are, and there is a pattern to this, as you all know. So the hip is L2, 3 at the front, L4, 5 at the back, so it just goes through the numbers, and as you go down a joint, it increases by a number. It's all relatively straightforward. You won't really be able to remember this in the clinic setting, but just have a vague idea of what muscles you might test for what particular nerve roots. So the examiner may say, I want you to test power in L5. And if you start by saying, well, I always start with the arms, the examiner will think you're bonkers. If you say, well, I'm going to test EHL, they'll be delighted. So you need to know what muscles supply are supplied by which nerve roots. So just have a think: hip flexion for L2, knee extension for L3. This is ankle dorsiflexion. We might have a discussion about whether ankle dorsiflexion is L4 or L5. L5, EHL, S1, flexor hallucis longus, and that fits with these reflexes. The knee L3, 4, ankle S1, S2. This isn't the way I do reflexes, and we'll show you much better ways this afternoon. And then some provocation tests. These are quite important, and you will often be asked about these, although it's quite rare to actually have someone in the exam, for example, who has sciatica. It's very common for you to have patients with widespread leg pain in your clinic, and you're trying to think, is this from the back? Is it a nerve root problem? Is it spinal stenosis? Is it diabetes? Is it vascular? Is it hip? Is it knee? And some of these tests will help. And certainly if you're seeing someone in A&E or as an emergency with Cordra-Quina syndrome or some other dreadful nerve root pain, you need to have a think about some of these tests. Which are the most useful ones? Laseg test, my test of choice, because the patients have never ever had it done to them before, so they have no idea that it's supposed to cause a lot of pain. The moment you put your hand behind the heel and attempt to do a straight leg raise test, certainly in Liverpool, and if there's a claim going on, you can't move them at all. What's the difference between the cross sciatic stretch test and the well leg raise test? You just need to have an explanation for the examiner as to what they mean. They're completely different tests. They mean completely and utterly different things. So we might talk about that this afternoon. And these other nerve root tension signs. So the straight leg raise is your standard one, supplemented by the sciatic stretch test. That's fairly standard. And you need to have a bit of an idea about the femoral stretch test. And always think about the lower sacral dermatomes. I see quite a lot of patients with sacroiliac joint pain, I think, and here are some of the tests, and we might talk about some of those tests this afternoon, and we can show you these if you're interested. And always consider sacral stress fractures. I see a surprisingly large number of older patients nowadays with dreadful lumbar spine pain who turn out to have sacral stress fractures. Baton signs, someone else mentioned Baton signs. The rheumatologists think that ligamentous hyperlaxity is a common cause of back pain in younger individuals. And it's always useful to just be able to screen for ligamentous hyperlaxity for a whole range of orthopedic conditions. So if you could make it look slick and the examiner can't actually hear the cogs clunking in your brain as you're trying to drag these out, that's quite good. What L signs? Sometimes we talk about these, and this is just my little list on the left, DROST, for what L signs, which you may be asked about. Examination of the cervical spine. Again, it's look, feel, move, and you have to have a think about how you're going to do this. So I often have the patient either standing or sitting for this. Both are perfectly reasonable, and you need to look, feel, move, stand and sit the patient. There are some other tests. Walk the patient first, and sometimes you'll detect some abnormal gait which makes you think that they might have myelopathy, for example. And then coming down, complete neurological examination and some provocative tests. Have a look and see what's what. The only abnormal sign I can see in this lady is a possible fixed flexion deformity of the right elbow for some reason. But on the right, you know, cock-robin deformity, you'll pick up deformities of the neck, and you need to just be aware of what these are. You need to feel the cervical spine. So you've looked from the back, you've looked from the side, you've looked from the front. Scars on the cervical spine at the back are usually fairly obvious because they don't heal that well. Scars on the front disappear really quickly. So if you're at all uncertain, you need to just ask the patient, is that a scar? And the examiner won't mind. They'll think you're thinking. So that's good. And so you've looked, and you're going to feel. I do the feeling next. You do need to stand reasonably close to the patient. Use both your hands. And it's quite good to be able to watch the patient's face in a mirror. You need to know if you're causing pain. And if they're standing up, you don't want to be pushing them over. That's quite easy to do. And this can all be done with the patient sitting just as easily. And then movements. Movements of the cervical spine, flexion and extension, lateral flexion and rotation. You need to be thinking, where do these movements occur? So if a patient has no rotation, you might be thinking, oh, this looks like it might be upper cervical spine. How do you measure them? And there's the tongue depressor method, there's the tendon hammer method, and there's the just guesstimating it method. We'll talk about those this afternoon. Romberg's test is often asked about with the patient standing up, and you'll know about this. Sensation in the dermatomes. So you've looked and you've felt and you've assessed movements, and you now come on to a neurological examination and other special provocative tests. So this is a diagram that I've got there, and these are some of the things. So most surgeons think the deltoid area is C5 and the index is C6. T1 is axilla, and C5 and T1 don't go to the wrist. But again, you have to know some of the autonomous zones, so you need to know, I'm going to examine here for C5, I'm going to examine here for C6, I'm going to examine here for C7, but there's a lot of crossover. You can say, and there is a lot of crossover. Think about the little finger and the ring finger and the middle finger. There's an important difference here between C8 and the ulnar nerve, and candidates are sometimes asked, so do you think this is C8 or ulnar nerve? And the poor candidate brains go to mush, and the good candidate says, well, here are the things I'm going to look at. I'm going to look at sensation in the ring finger. I'm going to, et cetera, et cetera. So think carefully about when you're examining the dermatomes. I just use fine touch. I just use my finger, and it's very rare that a candidate whips out hot and cold bottles in the neurological examination. It really throws the examiner. Muscle power and myotomes in the upper limb. You just need to have a quick way of whizzing through it, so that you should be able to examine all the myotomes and all the nerve roots in 30 seconds. You just need to have a plan about it. So, just make a pair of wings, keep your arms there, don't let me push them back down, bend your elbow, don't let me pull it out, push away from me. It just has to flow seamlessly, and as we said about examining the knee and examining the hip, if it looks fluid, the examiner looks fluid and practiced, and it looks as if you've done a neurological examination at least once before in your 6-year career, then the examiner will be reasonably impressed. Reflexes. Not quite sure, this isn't how I do the biceps reflex, though this might be a different type of reflex. We'll show you good ways of doing the reflexes, but you need to have an idea of what the nerve root values are. And so what is the implication of a dropped biceps reflex? You'll demonstrate an absent reflex, and the examiner will say, so what does that mean? And you'll go, oh, well, I don't know. So you do have to be thinking as you go along. That's really important. Some provocative tests, Sperling's test, you need to be able to know how to do that. The idea is you move the neck to nip the nerve and they get an increase in their pain. That's quite a useful test. You need to have a think about some upper motor neuron size. This is quite important, and we'll talk about this afternoon. And these are the ones that I tend to use. The Hoffman, the Clonus is very easy to do. You've got the patient up on the table. You just do that. Just this week, I saw a man who I was sure had a big disc prolapse in his neck, causing dreadful C6 nerve root pain, up on the bed, marked Clonus, and he comes back with a huge syrinx. So you will pick stuff up. So be very careful about that. And you can bet your bottom dollar if they do have upper motor neuron signs, the examiner's ticket will say, make sure they examine for that. And the examiner will say, anything else you want to do? And if you're lucky, they'll say, what about upper motor neuron signs? And then it'll suddenly click. So you need to have just some brief ones and a few of these to just go through. So today is about how to structure an examination. In other words, what to do. Eliciting physical signs, how to elicit these physical signs and make it look smooth and make it look as if you know what you're doing. But more than that, what does it mean? How do you interpret these things? And we're also here to clear up anything you want clearing up, but we're always too embarrassed to ask in the past. It's never too late to ask if you want some help. Thank you very much. Any questions? We can cover questions this afternoon, yes. Sorry? Well, usually they'll be provided. If they're going to be doing leg length measurements or Schober's test, there will be tape measures there. There'll be Coleman blocks tests. You don't need to take Coleman blocks tests to the clinic. What the candidates I've seen where equipment isn't provided is, for example, the 5 types of grip. And so candidates will suddenly whip out of their pocket a little key ring with a key on and a pencil on and so forth. And you just think, I'm not sure I'd have that at the clinic. And certainly, pulling out a pin and saying, I always test for pinprick sensation as a starter. The examiner says, this is orthopedics, not neurology, come on. And so forth. So probably not that much equipment. A tape measure may be the idea that in the exam, if there's tape measures, they're often paper tape measures, and they're not always that straightforward. So I'll probably take a tape measure, but probably not a lot. Yeah.
There's always a little bit of variation between autonomous. Is it reasonable for me to base mine entirely on the Asia charts, where they define each autonomous zone to do?
Yes. I think so. That's well standardised, well published. And if you worked in a spinal injury centre, you'll have undoubtedly used those. As long as you can explain. If the examiner says, are you sure? You just say, well, that's what I use when I do the Asia chart, and that'll usually shut the examiner up. Yeah.
Would in the exam come as a spinal case, and then we have to direct ourselves if this is cervical or lumbar, or would that be?
Well, sometimes there's a lot of help. In the intermediate cases, it's 15 minutes, and it's all about taking a history, integrating your examination to fit that, and coming to conclusions. Whereas the short cases is very different. The examiner will say, this man has arm pain coming from the neck. Examine his neurology, please. It's easy, because he doesn't want you to get bogged down in doing 3 minutes of walking them up and down, because you'll get no marks, and you'll think you've done well, and he'll think you've done pants. So the good examiner will direct you to exactly what he wants.
And in cervical, you have to mention what?
Have to mention what?
Horner syndrome, and we have to mention.
Just play it by ear. The examiner is there to guide you. Okay, he's not there to fail you. He's there to guide you. You fail yourself actually, but also he will tell you what he wants you to do.
Yeah, exactly. The examiners will tell you what to. So when you're looking at them, you can comment. I don't see any signs of a Horner syndrome.
We can take about 2 more minutes of questions related to lower limb or spine, and then we'll break for coffee, and then we'll come back. Any further questions?
So the lumbar spine examination, I'm sure it may be called after, but you said prone position examining the lumbar spine?
Yeah.
I'm not sure what test I'll be doing, because most of the tests I will do standing up.
You'll be pressing. You palpate the lumbar spine when they're lying down. So it covers palpation. So they're lying on their back to start with. You do everything with them lying on their back, and then you turn them over onto their front, and you just say, I'm just going to press on your spine, and I want you to tell me where it's sore.
And it would just do standing up, does it?
Well, the trouble with that is you can't put much pressure on, can you? And the patient will think, it's not really pressing very hard, no wonder it's not hurting. Whereas if you've got a big mechanical advantage, you're a big heavy bod like me, you can really press, and you can nearly always get some pain. Patients like to, oh God, you've hit the spot, doctor. You hit the button. Whether clinically it means anything at all, who knows? We imagine I'm pressing between the spinal processes. So if they have pain, it must be their disc. It's 6 inches in. Does that make sense? Probably not really.
So if we're back before 11, so this report, we may have a plan about how to see how it looks